Unclassified drugs do find two little chemicals at the end of this chapter that you need to hear of, whether for the exam or simply for common knowledge for practice. These are the drugs adenosine and the salt magnesium. Adenosine, you're hearing well, is actually the nucleoside of adenine. Adenosine is not only a nucleoside that we could phosphorylate to make DNA and RNA nucleotides with, it's also a bona fide neurotransmitter. It's actually often referred to in physio as a neuromodulator, since it is often co-localized with other neurotransmitters and when released controls a little bit how they work. Adenosine, nonetheless, has its own receptors. Call them adenosine receptors for the sake of that drug. They are really purine type of receptors. And adenosine finds some of its receptors in SA and AV node. Receptors to adenosine in those tissues are GI coupled. What does this remind you of? Hey, exactly. It sounds like muscarinic M2 receptors. And as such, you know that the decrease in cyclic AMP would result in a change in conductance of sodium, calcium, and potassium channel. Do you recall which one would now have conductance? Well, it's the potassium channel, isn't it? And potassium leaving a cell will hyperpolarize this cell. If you hyperpolarize this cell, no doubt it is less excitable. It's no longer firing as readily. When you decrease SA and AV node, we already know that this is for SVTs. And here's the deal. You have a drug here your patient has never taken as a prescription drug at home. So you're bound to have a response from that drug. No desensitization of receptors to that drug. Then you also have the fact that it is truthfully a neurotransmitter, meaning, guess what its half-life is? Yeah, you're reading right. Less than 10 seconds. Now you have in those antiarrhythmic the two extremes of pharmacology between amiodarone that lasted for months for a half-life and this one that barely has a few fleeting seconds as a half-life value. On top of it, when you see adenosine, ozine, that's adenine on a sugar. Sugars are water soluble. You put them in your coffee every morning or your tea if you don't like coffee, whatever it is. It means now I have an IV drug, ultra short half-life, guaranteed an answer from my patient. That becomes a DOC. DOC, drug of choice for paroxysmal supraventricular tachycardias. Paroxysmal supraventricular tachycardia simply means the worst they could ever get. They're no longer responding to your beta blockers or calcium channel blockers. Here's the problem though. You can expect adenosine as a neurotransmitter system to have receptors elsewhere in the patient's body. One very important spot it has receptors are on the bronchioles of the respiratory tree. And on the bronchioles, would you believe that the receptors to adenosine are actually GQ coupled? If you want, they're more like an M3 receptor. If that is the case, then what would you expect adenosine's effect on these GQ coupled receptor would be? Are you thinking bronchospasm? If you are, you're in good shape because that bronchospasm is a massive nuisance of the drug adenosine. You know, when we'll do these acute chest protocols in our hospitals and we'll use adenosine, if the patient is conscious, then we'll have to literally warn that patient that basically they're going to feel like they have an elephant sitting on their chest. They will not be able to bring some air in. Profound dyspnea, big bronchospasm. The luck we have is the half-life of the drug. With less than 10 seconds half-life, there's no doubt this is not going to last for long. But certainly enough to worry that patient, well, to death just about, which is what we're trying to avoid, isn't it? Now, where will I put a beautiful board relevance of this for my exam? Well, you see it as the last bullet point. I mean, put many stars next to this for your board exam on step 1. Adenosine is actually antagonized at its receptors by drugs like theophylline. Theophylline is a drug that you use in COPDs, chronic obstructive pulmonary diseases, particularly in people with asthma. Hey, obviously, if you antagonize the adenosine receptor, you are preventing adenosine from causing the bronchospasm. So surely you'd have a good effect in an asthmatic from that standpoint alone. But the other half of theophylline is not so good. If adenosine was a good drug for supraventricular tachycardia, slowing AV node, you can imagine that theophylline will result in a significant increase in AV nodal conduction. As such, expect drugs like theophylline to have as a toxicity the potential to cause ventricular tachycardia, VTAC. Well, ventricular tachycardias are, of course, potentially life-threatening. Theophylline is part of the chemicals that we call methylxanthines. And amongst the methylxanthines are also compounds such as caffeine, the theobromine of cocoa and of tea. And those compounds are very well established as causing palpitation in some of us. So you can imagine just what theophylline, a much stronger design type of drug for these receptor blockade, would result in. So here you have the good balance for your exam. Adenosine, drug of choice in SVTs, but causes bronchospasm. Theophylline, the adenosine receptor antagonist, a good drug in COPD like asthma, but causing ventricular arrhythmias. As to magnesium, Mg2+, in a way is very similar chemically, both in size and certainly in charges, to calcium. However, unlike calcium, it doesn't share its physiology. Once inside cells, magnesium is not part of the actin-myosin interaction system. Once inside a nerve terminal, it's not going to trigger neurotransmitter release, and so forth. So the way you could imagine magnesium having an effect in our patient is literally trying to replace calcium, compete with calcium's physiological effect. For instance, if a patient was to develop those life-threatening ventricular arrhythmias that we call torsade, then administering the magnesium might curtail, shut down the torsade rhythm. You know, magnesium is also used for patients who are coming in with seizures, for ladies who are coming with premature labor, very much indicating to us that although it's not well established, it seems like magnesium has a competition effect with calcium. Now, if we think of torsade, that life-threatening ventricular arrhythmia, it is not only associated with electrolyte imbalances, some of which you can read in your notes in the margin of your syllabus, but also because of drugs. And the primary fact of a torsade is to maintain cells depolarized. To maintain cell depolarized, anything that can actually close a potassium channel will prevent potassium efflux. And if you can decrease potassium efflux from any of the dozens of subtype of channels, then you'll keep potassium in the cell, leave it close to threshold, and potentially start having these prolonged QRS complexes on your EKG and prolonged QT interval that are so characteristic of torsade. To decrease potassium efflux, I think one of the group of drugs we'll agree on are the antimuscarinic drugs. And I mean by this, go back to this ANS section when we reviewed atropine together. You remember the long list of antimuscarinic drug? It certainly wasn't atropine, was it? It was also every single antipsychotics, all the TCAs, antihistamines, they're over the counter, most of them. Drugs like meperidine, amantadine, of course our quinidine that we saw earlier on, all these share the antimuscarinic pharmacology. But other potassium channel blockade would do the same job, such as a class 3 drug like amiodarone. Certainly, it means a number of antiarrhythmic themselves can cause a pro-rhythmic effect of torsade. Well, this concludes our antiarrhythmic pharmacology chapter, the toughest one of the entire section. Next time you're going to struggle and sweat, it will be for the diuretics in this section.